Hello, everyone, and welcome. It is now 3 p.m. Central Time. Let's get going. Welcome to our free webinar Wednesday, where today we're going to talk about all things maternity. My name is Jennifer Bonner. I am one of Archer's private tutors, but I'm also a lover of all things maternity, labor and delivery, postpartum, in between. I love it all. So I have been a nurse for 14 years. I started in a stroke ICU, moved into endoscopy, finding my love for women's health in labor and delivery and postpartum was just the most amazing experience. I went back to school to become a certified nurse midwife and practiced for about 3 to 4 years before I went into education. So I am so excited that you are here joining me this afternoon. So I want to know, can you let me know in the Q&A, where are you joining me from? Let me know where you're joining me from in the Q&A. From Texas, Miami, Seattle, Florida, Indiana, Chicago, New York, Arizona, California, New York, Texas, New Mexico, South Carolina, North Carolina, North Dakota, Canada. We got someone from Calgary, Australia. Welcome, welcome. Maryland, Istanbul. Welcome. Philly, Ohio. That's my home state. Atlanta, Canada, Tennessee, Colorado. We have we have Canada, Tallahassee, Kuwait. Awesome. Well, welcome everyone, regardless of where you're joining us from. I am just thrilled that you're here. So, welcome. Over this next hour, we are going to discuss all things maternity. We're going to work through a little bit of a case study. We're going to talk through those main high yield points that I really want you to know. And we're going to have a great time while we're here. So, why don't we go ahead and let's meet our client. Mrs. Jones is a 31-year-old female. She calls her OB provider and states she thinks she's pregnant. She's had a positive pregnancy test, is really tired, and lacks energy. What sign of pregnancy is a positive pregnancy test? So we notice she has a positive pregnancy test, probably why she's calling her provider's office to let them know. What sign of pregnancy is positive? So, we have three different um, types of pregnancy symptoms that we talk about. We talk about positive, presumptive, and probable. So let me know which one is a positive pregnancy test. I'm seeing some probable. So we're asking about the fact that she's had a positive pregnancy test. What type of pregnancy symptom is that? Is it probable, positive, or presumptive? I'm seeing probable, presumptive, positive. Seeing a lot of probables, presumptive, lots of answers here. So let's talk about our different signs of pregnancy. So the ones that we start with are the presumptive signs of pregnancy. And so when we talk about presumptive, I want you to think about the word presume. I would presume you're pregnant if you notice these things. And so when you think about the word presume, those are going to help you with the presumptive signs of pregnancy. So an absent period, really tired, enlarged breasts, sore breasts, urination frequency, movement perceived, emesis, and nausea. Now, those symptoms can be linked to various other conditions, right? So, what about amenorrhea? What could cause that other than pregnancy? What could cause amenorrhea other than pregnancy? So you can go ahead and answer questions right in the Q&A. What other things can cause amenorrhea? Anorexia, menopause, that's a great one. Hormone changes, PCOS. So when we're thinking about the different signs of pregnancy, these are things that mom is experiencing, but we categorize them in these three categories. Hormone imbalance, birth control. Okay, that's a good one. Obesity. Yeah, so women who are, let's say they're training for a marathon, they're very, very active. A lot of times they will have amenorrhea. Women with PCOS, where they're not ovulating, a lot of times, amenorrhea. Malnutrition, chronic diseases. Yeah, various different diseases. Menopause is a big one. So we know menopause is going that year without a period. So there are other things that could be related to the amenorrhea, right? Not necessarily just pregnancy. What about being really tired? Well, maybe they have young children at home and they've been up at night. Maybe they're in, I don't know, nursing school and they've been studying, they've been in clinical all day. There are lots of different reasons why we can be really tired. Anemia is another one. Urination frequency increased. What else that's a big one could cause a increase in urination frequency? Let me know in the Q&A. What do you think? There's a big one I'm looking for. UTI, yes. Diabetes is another one. UTI is a big one. So there are other things. So when we think presumptive, we want to think, yes, it could be pregnancy, but there are a plethora of other things that these symptoms could be. An emesis and nausea. Yes, it absolutely could be an early pregnancy. It could be the fact that they ate some nasty sushi yesterday. It could be that they just have a really bad tummy bug. There are a lot of other things that can cause presumptive signs of pregnancy. But when we have these, we presume you could be pregnant. Now, what about probable? When you see the word probable, I want you to think you are probably pregnant. Okay. So these are things that, yeah, maybe there are a few other things that could cause these certain things to happen, but probably it is pregnancy. So if you have a positive pregnancy pre- positive pregnancy test, chances are you're pregnant. Now, someone had asked in the Q&A, is it possible for certain types of cancers to cause a pregnancy test to be positive? Absolutely, that does happen from time to time. But generally, if the pregnancy test is positive, our client is pregnant. Now, we also have things like Goodell sign. Goodell sign is the softening of the cervix. So generally, someone just in the middle of, the beginning or the end of their cycle, the cervix is a little more hard. Goodell sign is that softening of the cervix, generally about 4 weeks gestation. We also have Hagar sign. Hagar sign is a softening of the lower uterine segment of the uterus. So if you picture the uterus is kind of like an upside down pear, so kind of like that. The bottom portion, that lower uterine segment of the uterus becomes softened, and that is Hagar's sign. And then we have Chadwick's sign. Chadwick's is where we get a bluish discoloration. This can be to the vagina, the cervix, the vulvar area, and that generally happens around 6 to 8 weeks. Sometimes our clients will notice this, but a lot of times it's when they come in for an exam and the provider will notice these things. So that's Hagar's, that's Chadwick's, and Goodell sign. We can also have an enlarged uterus. Well, if the uterus is growing, chances are there's probably a growing fetus in there. So think probable, chances are you are probably pregnant. Now, our last category is positive. When I see these symptoms, I am positive you are pregnant. This is when the healthcare provider is noting fetal movement. Now, a lot of times, even when I'm not pregnant, sometimes I feel gas bubbles that occasionally do feel like those early movements of a fetus. And so sometimes women can feel those things. But as that fetus continues to grow, there's more pronounced movements. There's kicks, there's punches, there's rolls, there's things like that. But when the healthcare provider starts to feel these things, they are positive that you are pregnant. If there's an electronic device that's detecting a heartbeat, that could be a Doppler, that could be a fetoscope, maybe not a fetoscope, but a ultrasound, then we are sure that there is a baby in there. When you deliver a fetus, when you deliver a baby, we are 100% sure that you were pregnant. When we see a baby on the ultrasound, 100% you are pregnant. And we're starting to see those movements by the healthcare provider. So notice that we move from presumptive. So, yeah, those are some pregnancy signs and symptoms, but they could also be linked to a bunch of other things. Then we move into probable. So chances are you're probably pregnant if you're experiencing these things because there's not a whole lot else that could be related to positive. 100% sure we're seeing this baby, we're hearing heart tones. All right, so what happened? So the nurse asked Mrs. Jones when her last menstrual period was. She states it was 10/25/22. How are we going to calculate her expected due date? There's a particular formula that we're going to use to calculate an estimated due date. What is that formula? Do you remember? Let me know in the Q&A here. So GTPAL is a great answer, but that doesn't help us calculate a due date. That's going to help us determine how many pregnancies has she had, how many were preterm, how many were term, how many were aborted, and how many does she have currently living. Many of you aren't giving me the rule, but you're giving me how we determine it, and it's right. It's Nagel's rule. Excellent job. Nagel's rule is we're going to take that first day of the last menstrual period and we're going to plug it in to determine what the due date is. So, how are we going to do that? Well, many of you alluded to this in the Q&A, and that is absolutely great. So, we're going to take that first day of the last menstrual period, and we're going to go ahead and add 7 days to that. Then we're going to subtract 3 months and adjust the year if needed. And that's going to give us our estimated due date. So, let's see, when was her last menstrual period again? 10/25/22. So let's see if we can work through this one. So 10/25/22, we're going to take that last menstrual period date. We're going to add 7 days. So that gives us 11/1/22. Have you ever had to do that rhyme in your head? 30 days have September, April, June, and November. All the rest have 31 except for February that has 28. Sometimes I have to run that through my head, and that is totally fine. So we add our 7 days. That gives us the 1st of November of 2022. Then we're going to subtract our 3 months, and that gives us 8/1/22. And then we're going to adjust the year because that's going to roll into the following year. So that gives us 8/1/23. Excellent job. Many of you have already put that in the Q&A. Excellent job. Now, let's talk about some of those weekly developmental milestones. So, at Mrs. Jones' first appointment, it's determined that she is 11 weeks gestation. What developmental milestones have occurred by that point? Can you think of those developmental milestones that may have occurred by that 11-week gestation? Developmental milestones of the fetus by 11 weeks. Heartbeat, So a lot of times, yeah, by then we can hear a heartbeat through the Doppler. Now, sometimes that depends on the body habitus of our client. And so when I would go in to see a client, we're first having that opportunity to listen to the baby's heartbeat with the Doppler. A lot of times, the first appointment, women are very nervous. They're very scared that they're not going to have a heartbeat, or maybe they've gotten their hopes up and they're very excited to be pregnant, but maybe we discover that there isn't a heartbeat, or the baby, has passed away. And so I always let them know, hey, we're going to try to listen with the Doppler today. If we don't, we're just going to grab an ultrasound. No big deal, just to give them a little bit of reassurance. All right, let's take a quick break here. One thing that I want to highlight is our small group tutoring. At Archer, we love our students. We have such a passion for education. We have such a passion for you. Do you know why? Because we are you. We've been there. We've been in the situation where we are wringing our hands trying to understand these very difficult concepts. And so we are dedicated to your growth and to your learning. So we have several small group tutors. We have Megan, Kate, Rachel, myself, Elizabeth, Lauren, and Emma, all offering various small groups from various different topics, from maternity to NCLEX prep. So if you are interested, go ahead and scan that QR code there. That will take you right to our small group page. Those are $25 for an hour session and are a lot of fun. There's a lot of learning that happens there. There are lots of opportunities to grow and to learn from each other. Okay, so let's hop back to our first trimester. So during the first trimester, that fertilized egg is going to change from a small grouping of cells into a fetus that's starting to have baby features that we know. Okay, so on month during month one, we kind of have this all or nothing effect. If the embryo is exposed to harmful teratogens at this point, because the organs haven't formed, it will either cause the pregnancy to be lost, it will cause an abortion or a miscarriage, or if the pregnancy is not lost, nothing happens and we just continue on. Okay, so that's during month one. In month one, we consider that weeks 1 to 4. So generally, when we're talking about pregnancy, our weeks, our months, we consider a month to have about 4 weeks in it. So month two are weeks 5 to 8. So we notice those facial features are continuing to develop. The neurotube by that point is well formed. And at 6 weeks, that baby's heartbeat can be detected via ultrasound. At month three, so the next 4 weeks, so 9 to 12, we have the circulatory and the urinary systems are functional. So by the 8th week, that developing baby, we start to refer to it as a fetus instead of the embryo. So we have hands, arms, fingers, feet, toes. They're fully developed and they start to explore opening and closing their fists and their mouth. This is really exciting. So there's a lot of growth that's going on there. Okay, so let's see what's going on now. So we need to calculate Mrs. Jones's GTPAL. We alluded to this just a little bit ago, but we need to determine what her GTPAL is. Along with this current pregnancy, she has a history of a healthy delivery at 38 weeks and an emergency C-section at 29 weeks, where the child did not survive. So, what do you think Mrs. Jones' GTPAL is? Let you take a couple seconds here to work through that one, and then we'll talk through it. So, she is currently pregnant, has a history of a healthy delivery at 38 weeks, an emergency C section at 29 weeks where the child did not survive. I'm seeing some right answers coming in already. Excellent job. Excellent. Angelica, Bernice, Sweeta. Okay, so let's talk through this one. So our answer here is G3, T1, P1, A0, and L1. So what does our G stand for? Gravity, gravidity. Our T is term, our P is preterm, our A is abortions, and our L is living. So we know that she is currently pregnant. She had a 30-week, 38-week delivery and a 29-week delivery. So that makes her a G3. Now, how many of those were to term? Well, when we determine what's to term, we need to know what determines term. Well, a term baby is at 37 weeks, not 36 and 6. That's considered preterm, 37 and above. And so she had a 38-week. So that's a T1. Preterm, so that's anywhere between 20 weeks and 36 weeks and 6 days, or we call that 36 and 6. So she had that 29-week delivery. And then our L is our current living children. So she only has the one living child since she's currently pregnant. That child has not been delivered yet. And then her 29-week delivery did not survive. So she's just a L1. All right, so let's break that down a little bit more, shall we? So we talked about how gravidity, it's the number of pregnancies, but the tricky thing here is that we need to remember, is she currently pregnant or is she not? Because sometimes that can be a little tricky and it gets thrown in there pretty quick. So we need to determine, is she currently pregnant? So the number of pregnancies, including the current one, twins are only going to count as one pregnancy. Now, what about T? T is term. So the number of pregnancies that have been carried to term. Now, this is the place where we're not going to count the current pregnancy. We want to know the ones that she's delivered. So this is the number of pregnancies that are carried to term. And we determined that term is 37 weeks and beyond. Twins, again, they're only going to count as one in the term column. Now, what about preterm? So these are her number of preterm births. So preterm births, we count those from 20 weeks to 36 and 6 gestation. And again, twins are only going to count as one. So even if there was a demise and the baby was, let's say, 22 and 3 weeks, that still counts as preterm because it's after that 20-week mark. Now, let's talk about abortions. Abortions can be a little complicated. So, A stands for abortion. That's the number of pregnancies that ended prior to 19 weeks and 6 days. So, just before that 20-week mark. This can be a spontaneous, so a miscarriage, or it can be a termination, an elective termination. If the abortion or miscarriage was after 20 weeks gestation, we count that under the P because it was after the 20 weeks. So that's our mark. Okay, so abortions is before 20 weeks. Preterm is before 36 weeks and 6 days, or 36, including 36 weeks and 6 days. And then term is 37 weeks and beyond. Now, what about living children? Now, this is where twins get to count as two live births. So this is the current number of living children. Does that make sense? So G is gravidity, how many total pregnancies, and counting the current one. T for term, so how many babies 37 weeks or past. P is preterm, so how many babies 36 and 6 to 20 weeks. A is abortion, so how many were lost before 20 weeks? So that's 39 weeks, excuse me, 19 weeks and 6 days before that mark. And then L is current living. So the +6, someone is asking, what is +6? So that we know that there are 7 days in a week. So once it's just 1 day shy of that week mark. So let's say she turns 37 weeks tomorrow. Today she is 36 weeks and 6 days. So we say 36 and 6. Okay, so Mrs. Jones states she's concerned about her nutritional needs now that she's pregnant. What nutritional needs would you want to educate her on? So Mrs. Jones is pregnant. She's concerned about what those nutritional needs are. What would you educate her on? What kinds of foods, supplements would you encourage Mrs. Jones to consume? Folic acid. Folic acid is a great one. Maybe some foods high in iron. Okay. Hydration. Hydration is a great answer. We know that that blood volume is going to increase as she's providing that for another human life. So keeping her hydrated is going to be helpful there. Fiber can help with some of those things that come with pregnancy, like constipation, prenatals, calorie intake. Excellent. You guys have some great answers. Okay, so let's talk about some of those nutritional needs. So, proteins, complex carbs, fibers, healthy fats, all of those are really, really important. Generally, pregnant women are going to need about 300 additional calories per day in order to support their growing fetus. So, a lot of times, what we'll hear is women say, I'm eating for two. And while that is partially correct, and we don't want them to go overboard, but there is an increased caloric intake that's needed in order to support that growing baby. So, let's talk about those proteins for a minute. So lean options are ideal for these. So we want to look at white meats, dairy, eggs, beans, nuts. Those are great places to find good protein. And those are also needed for fetal growth, especially during the development of their muscle and tissue. Now, what about complex carbs? Well, we want to look at whole grains, beans. These are going to give lasting energy, especially when those early pregnancy days, a lot of pregnant mamas are very, very tired. So we want to avoid those simple carbs, especially with someone with gestational diabetes. That's going to raise their blood sugars. Now, what about fiber? Well, we talked about how there are a lot of different effects on the body. So the GI system kind of slows down a little bit. So constipation is very common in pregnancy. So this is a complex carb that we a lot of times find in plant foods and legumes. And this helps with a healthy digestive system, helps with constipation. And then healthy fats. It is important for us to get some of those fats in our nutritional intake because it's also going to help us with energy, not only for mom, but also that developing fetal organs and the placenta. So things like avocados, those are great sources of healthy fats, seeds, fish. Now, let's talk about fish for just a second. So there are certain types of fish that we want to want to avoid. Fish that are high in what are types that we want to avoid? There's a specific thing we want to avoid. Fish that are high in mercury. Excellent. So we want to avoid those types of fish and be very careful with them. So we want to avoid things like big eye tuna, mackerel, swordfish, shark. Oily fish are best, so like fresh tuna, sardines, but we want to limit to about 2 portions per week. Now, a lot of you had mentioned some supplements, so let's talk about those for a minute. Folic acid is a big one. Typically, in our normal prenatal vitamin, there is some. And what this does is it helps prevent birth defects of the spine and the brain. It helps prevent those neurotube defects. We generally like moms to be taking this prior to becoming pregnant, but for sure, when they find out, we definitely want them taking those. Calcium is a good one, not only for mom's bones, but also fetal bone growth, also teeth development. Vitamin D. Vitamin D helps to build fetal bones and teeth, again, just like calcium. Iron, many of you mentioned iron. This is going to help mom create more blood, more oxygen carrying capacity to support fetal oxygenation. Remember, she's circulating for two now. So, iron is going to help her get that support that she needs. Now, she can find that in supplements, she can find that in various foods. DHA, this is an omega-3 fatty acid, and this is gonna help with eye and brain development of the baby. And then iodine. This is important for fetal brain and nerve growth. Now, like we talked about before, when we are talking about supplements and nutrition, it's important that we not only talk about the foods that are important, but we also want to be careful with foods that need to be avoided. So we talked about fish that are high in mercury, cold deli meats, hot dogs. Why would we want to avoid those? Well, when we don't know where they've come from or if they how long they've been sitting out, they can have bacteria. So we want to be really careful with those types of things. We want to, it's definitely okay for the mom to have deli meat, but what we encourage her to do is make sure that you cook it to where it's steaming, to where all of that bacteria has been cooked off. Raw meat and eggs, again, same reason. Unpasteurized dairy products, pate or liver. So these are high in vitamin A. And at high levels, this can actually cause congenital defects in the cardiac and the central nervous system. It can also increase the risk of spontaneous miscarriage. So we definitely want to avoid those. Now, what about unwashed produce? Contrary to my children's belief, um, we definitely need to wash our produce because we don't know how many hands have touched them, what else has been on them before we consume them. So it's really important that whatever type of produce, we definitely want to be eating those fruits and veggies, but we want to make sure that those are cleaned and washed very well. Now, let's talk about caffeine. Caffeine is one of those very important subjects for a lot of mamas when they come in. They want to know, do I have to completely cut it out? Can I have a little bit? We generally say limit it to about 200 milligrams or less, no more than a 12-ounce cup of coffee a day. Okay. More than that can lead to placental umbilical cord vasoconstriction, and that can decrease fetal oxygenation. So we want to be really careful with that. And then alcohol. Alcohol at high doses, excuse me, can actually cause fetal alcohol syndrome. That can cause multiple facial deformities, growth issues in the bones and joints, vision, hearing problems, learning disabilities. We encourage mamas that know they're pregnant to avoid those types of beverages. Okay, so let's take a quick break and let me tell you about something that I'm super passionate about. While I absolutely love teaching in small groups, one thing that has been the foundation of my growth as an educator is one on one private tutoring. Let me tell you why. I love the opportunity to get to work one on one with students because then I find out where is it that you're struggling? Maybe you know, maybe you don't know, and we have that opportunity to work together. So we can individualize a plan for you to help you not only understand information, but also making a plan going forward. Maybe you need help developing a study schedule. Maybe you need help with your ability to answer NCLEX style type questions. Well, one of these amazing experts in the field of nursing is here for you. So a lot of the same faces that you saw that are providing small groups, are offering one-on-one tutoring sessions. These sessions are $75 an hour, but it is totally tailored to you. So what we're going to do is we're going to find out, where are you struggling? What needs do you have? How can we help you be successful? A lot of times, students just need to be reminded you're not defined by the NCLEX. It doesn't determine whether you're an amazing person or whether you're an amazing nurse. It's a hurdle that we have to jump, and you are not defined by that. So if you're interested in checking out our one-on-one private tutoring, go ahead and scan the QR code, and that will bring up the current availability. All right, so back to Mrs. Jones. 2 weeks later, Mrs. Jones calls and states she can't keep anything down, including fluids. What are we concerned about now? So Mrs. Jones, it's been a couple weeks. She calls, she says, I can't keep anything down. What are we concerned about? Okay, maybe fluid volume deficit. Maybe she's a little dehydrated. Because she's dehydrated, we have an imbalance of electrolytes. Hyperemesis gravidarum. Malnutrition, maybe. Yeah, so if she's not able to keep anything down, she's not getting enough fluid, not getting the nutrition that we just talked about. Absolutely. Great job. So you're right. Hyperemesis gravidarum. Now, what does this mean? Well, this is more than just your average morning sickness, a little bit nauseated here and there. This is extreme, it's over the top. So, what happens here is we have this intense nausea and vomiting during pregnancy. And a lot of times, women will tell us, I can't keep anything down. So over here on the right side of your screen, you're going to notice that there's a little bit of a chart showing you the difference between these two very similar subjects, morning sickness and hyperemesis gravidarum. I would encourage you, if you're struggling between two very similar topics, put them side by side and talk about what makes one versus the other. This is a great way to learn, especially if you're a visual learner. So with morning sickness, they have some nausea. Sometimes it can cause some vomiting, but generally that nausea is going to go away around 20 weeks. Generally, they're vomiting here and there, but it's not causing an issue with dehydration. And most of the time, they're able to keep some food down, just maybe not everything. Now, with hyperemesis gravidarum, remember, this is extreme morning sickness. So we have nausea, excessive, persistent vomiting. It a lot of times will last past 20 weeks. It's not going away. And because we have that severe vomiting, excuse me, we have dehydration, weight loss, electrolyte imbalances. Those are not great recipes for a healthy fetus, right? We're trying to make sure that we're getting adequate nutrition, adequate hydration to be able to provide for that baby. They're not able to keep anything down. So those are our major differences between morning sickness and hyperemesis gravidarum. So a lot of times when we have hyperemesis gravidarum, we will prescribe various medications. There are occasions when women need to be hospitalized. So let's talk about when we need to be concerned. Are they losing weight? How much weight are they losing? Are they dehydrated? So when a pregnant woman gets dehydrated, a lot of times she will get very dizzy upon standing. Maybe she's in the hot shower and that causes some dizziness, which creates a risk there. So, how do we determine whether she's dehydrated or not? Well, we're going to look at the skin turgor. Her mucous membranes, are they pink? Are they moist? What's her heart rate doing? When we're dehydrated, our heart is trying to compensate. Electrolytes. So, when we see dehydration, we think hypernatremia. Okay. When we're vomiting, we have a lot of vomiting, we think hypokalemia, hypochloremia. Okay, so we've determined that she has hyperemesis gravidarum. What are we going to do about it? Well, a lot of times the first things that we recommend are those dietary changes, easy things that can do at home. Just like we were talking about with iron supplements. A lot of times we can find foods that are high in iron and avoid taking an additional medication. So we're going to talk about some dietary changes. Sitting up after meals kind of help let everything start to digest. Have a few crackers before getting out of bed, something to just settle the stomach before you start your day. Having smaller, frequent meals throughout the day. Now, generally, we are consuming three large meals throughout the day. We have breakfast, lunch, dinner. Well, in this situation, we might recommend a small breakfast and then a snack, a smaller lunch, and then a snack, and a small dinner, and maybe a snack after that. So we want to portion that food out kind of over throughout the day. We're not going to do liquids with meals. We're going to actually drink in between. And then we're going to avoid those too hot, too cold, spicy foods. We're just going to kind of keep it simple. Remember the brat diet, bananas, rice, applesauce, toast. We don't have to get that crazy, but sometimes that is helpful. The other thing we might consider is if those things aren't working, we might want to consider different medications. Now, when we look at medications, we need to do this risk benefit assessment. The decision to use any type of medication during pregnancy is going to involve careful assessment of the potential risks and the potential benefits. Okay. We know that nausea and vomiting during pregnancy or morning sickness are common, and most cases are not going to require medication. Lifestyle changes, dietary modifications, these are often the first line treatments, just like we talked about. Medications are typically considered when symptoms are severe. They are significantly impacting that pregnant woman's well being. And a lot of times we will talk about promethazine. Occasionally, like we discussed earlier, she may need to be hospitalized to get some IV fluids. And in extreme cases, TPN is another option. Now, something else that we need to consider when we're talking about promethazine is a safety profile. So, this is in a class of medications called antihistamines. It's been used for many, many years to treat nausea and vomiting in pregnancy and has a relatively long history of use. It's generally considered safe when used appropriately under medical supervision. But, like all medications, it's not without those potential side effects or risks. There are some alternatives we can think about to treat nausea and vomiting during pregnancy. Vitamin B6, doxalamine, which is an antihistamine. These medications are often recommended as first line treatment. Um, Unisom is a trade or a brand name that a lot of times we'll see used with B6. And then we look at individualized treatment. So the choice of medication can vary based on the individual's medical history, their allergies, their specific circumstances, and some women might respond better to one medication than the other. So it's very individualized. All right, so now Mrs. Jones is at 28 weeks. Her vomiting is finally under control. Her provider tells her it's time to do a glucose tolerance test. Oh man, is she about to have some fun? Okay, so let's talk about the different types of glucose challenge tests that we see. So, generally, the first oral glucose tolerance test is done in about 28 weeks. Unless there are other risk factors, then sometimes providers will order that early. Now, at 28 weeks, what happens is mom is given a bottle of a oral solution that has 50 grams of glucose in it. She drinks that over about 5 minutes, and then 1 hour later, we check her blood sugar. If that blood sugar is greater than 140, it's out of range, then we order a 3 hour glucose test. Okay. So basically, we use this as a screening tool. If it is abnormal, then we do a 3 hour glucose tolerance test, and that is going to determine gestational diabetes or not. So once that 1 hour is failed, if the 1 hour is failed, we order a 3 hour. And this is done fasting versus the 1 hour. Generally, they can go about 2 hours without eating, no big deal. The 3 hour, we want them to be fasting. So about 6 to 8 hours prior to that test, more so on the 8 hour mark. So what happens is she goes into the lab, they check a fasting blood sugar. And then she drinks the same amount of solution, but this time it has 100 grams of oral glucose in it. So it's much sweeter than the first one. And then we check her blood sugar 1 hour, 2 hours, and 3 hours later. Okay. So for our 3 hour glucose tolerance test, if we're talking about fasting, normal is less than 95. Okay, fasting normal is less than 95. A 1 hour less than 180 is normal. A 2 hour less than 155. And a 3 hour is less than the 3 hour is less than 140. So let me say those again really quick. Fasting less than 95 is normal. 1 hour less than 180. 2 hour less than 155. And 3 hour less than 140. So the diagnosis is made for gestational diabetes if the fasting blood sugar is greater than 95 or two of the other three lab values are high. Okay, so what about Mrs. Jones? Well, her blood glucose with the 3 hour test is 163. Does she have gestational diabetes? Let's say that's her fasting. Let's say Mrs. Jones' fasting blood sugar with her 3 hour test is 163. Absolutely, it's greater than that 95. Nice job. So let's talk about gestational diabetes. What is it? Well, gestational diabetes is diabetes that's diagnosed in pregnancy. It's not something that she had or that was caught before. And so basically, what happens is that pancreas is unable to deal with the increased need of insulin because of the pregnancy. So, what happens is we have an increased insulin resistance because of the hormones that are being released during pregnancy due to the placenta. Okay, so we have a change in our carbohydrate metabolism. So, a lot of times we're able to have what's called diet controlled gestational diabetes, which is where a woman is able to control her numbers just with diet alone. Other times she's going to need a little help with different medications. Now, what are the things that make a woman more at risk for gestational diabetes? Well, obesity and being overweight is one of those risk factors. That's very similar for just diabetes in general, right? A sedentary lifestyle, so someone who's not very active. If she has had prediabetes in the past or has had gestational diabetes with a previous pregnancy, PCOS, someone who's already has insulin resistance, if they have diabetes mellitus, a history of a baby that was greater than 9 pounds, or they are of the ethnicities of Black, Hispanic, American Indian, and Asian Americans. Those all increase the risk factors. Now, what's our assessment going to look like? So, we're going to screen for gestational diabetes generally around the 24 to 28 week. 28 week is most common. And we're also going to screen for glucose in the urine. Now, what can happen? What can some of the complications be of someone with gestational diabetes? Well, we can have babies that are very large. A lot of times we see this when the diabetes is not able to be controlled. Preeclampsia, the risk of preeclampsia also increases with gestational diabetes and hypoglycemia of the infant. So, what happens is the baby is used to having mom um, take care of its glycemic needs, right? Getting the glucose and the insulin and all of that. And then once the baby is born, it's like, wait a minute, I have all this extra stuff because that's how I was dealing with the glucose from mom. And so there's not as much glucose for baby. And so a lot of times they become hypoglycemic. So these babies can be delivered earlier because of their likely larger size. Like I said, this is not every child, more so likely with those who are either undiagnosed or unmanaged. And the thing that we need to consider is that a lot of times these gestational diabetes or diabetes babies, a lot of times they're gaining a lot of their mass in their shoulders, which can be a problem during delivery. So a lot of times a C-section will be discussed. Also, untreated or unmanaged gestational diabetes can increase the risk of a stillbirth. So, what do we do for these women? Well, there's a couple things that we can look at. Like I said, we can control with diet and exercise. So, just like many other things that we've discussed today, whether it was supplements or nutrition, maybe it was hyperemesis gravidarum. There are things that we can do with just diet alone. And sometimes that's sufficient, and other times it's not. The other thing that we're going to look at is monitoring that blood glucose. So, what that looks like is mom will get a glucometer. She'll check her blood pressure or her blood sugar. Goodness, first thing in the morning, that's her fasting. And then she's going to check it either 1 or 2 hours postprandial, so after each meal, and see if her numbers are falling in range. Generally, mom should not require insulin after delivery. But it is important, and a very high yield topic for NCLEX, that baby is at risk for hypoglycemia. So a lot of times they'll be checking baby's blood sugar as well, just to make sure everything is good to go. Now, what about baby? Well, the fetal pancreas is producing its own insulin, right? So it was used to those high levels of glucose in mom's blood, especially if it wasn't controlled. So baby's pancreas is making its own insulin to deal with the glucose it's getting from mom. After delivery, mom's not giving that high level of glucose. So that's not what baby has, but baby's still producing that much insulin. They have this lingering insulin. And so their blood sugar goes down. So mom has high glucose, baby gets a lot of sugar while they're in utero, baby gains weight, and generally they are born large. And we consider them macrosomic if they are greater than 4 kilograms. So we encourage mom eat those foods that are high in fiber, whole grains, veggies, aim for about 30 minutes of exercise daily that's about mild to moderate. But again, we want to make sure that we are paying attention to our fluid necessity, making sure that we are getting enough fluids in there, we're hydrated well. And then we want to try to gain weight slowly. A lot of women, when they are diagnosed with gestational diabetes, a lot of times they even tend to lose weight because then they start focusing on their diet. So we want them to try to gain weight slowly and ideally start their pregnancy at a healthy weight. All right, Mrs. Jones gets her blood glucose managed with insulin. So those dietary, those exercise, components weren't enough for her, so she ended up with some insulin, and she states she finally feels better at this point and will see us at her next appointment in 2 weeks. Successful visit. Awesome. So this is a great time to stop and talk about one of our number one recommended package. This is our SurePass combo. So if you want to scan one of those, so we have RN on the left, PN on the right. One of those codes will bring you to give you more information on our SurePass combo. So this is going to include your on-demand videos, your Q bank, and the 3-day live review. If you've never attended our 3-day live review, it is so much fun. Well, at least I think it's fun. It is what I call nursing boot camp. Okay, so we have 3 days of time when we are talking about all things nursing school, all things NCLEX. We're talking about how to answer NCLEX questions. We're talking about high yield topics from anything from mental health to electrolytes to endocrine. We're talking about all of those sticky subjects. You have opportunities to interact one-on-one with our experts. It is a jam-packed 3 days, lots of resources available. So go ahead and scan if you're considering the RN versus the PN to get more information on our SurePass combo. Now, here at Archer Review, we're more than just test prep. We take our dedicated team of knowledge and we want to help you be a successful future nurse. We are invested in your success. We recently got an email from a student thanking us for just investing in her, and it is our absolute pleasure. It's not just a job for us. We enjoy working with our students. We enjoy investing. We enjoy hearing your success stories. But even we want to hear where you're still struggling so we can still help. So it has been an absolute pleasure having you with us today. Thank you for joining me for all things maternity. So let me know in the chat, how did you start off feeling about maternity versus how do you feel now? How are you feeling about the subject of maternity now that we've kind of been through a case study? can let me know in the Q&A. Feeling better, feeling easy. Absolutely loving maternity, one of my favorite classes. Mine too. It is. Yeah, so there are a lot of different topics that can be struggles for each person. And so sometimes it just depends on what those are as to where you need to focus. But let me encourage you that when you're focusing only on one certain topic, a lot of times we're losing knowledge in others. So make sure that while you are focusing, let's say it's maternity, that you're still engaging in other questions for pharmacology, mental health, pediatrics, more confident assessments, ask more questions in depth on maturity. Yeah, so this was just kind of an overview. I am so excited that you joined me. Thank you so much. I hope to see you in either a small group or a one-on-one. Thank you for joining me and have a great day.